Dear audience, I welcome you to our another educational session of International Educational Series. The topic today is about anterior uveitis, the things which are very important to be known to the ophthalmologists. We know that every ophthalmologist encounters this disease in his career. And what are the very important features of this disease? We will discuss it today, which must not be missed. In order to discuss this topic and educate us, we have once again invited Dr. Abdul Sattar Nasser Farag. He is a uveitis consultant in Manchester Royal Eye Hospital, Manchester University, NHS Foundation Trust. Dr. Abdul Sattar has done fellowship in uveitis from Bristol Eye Hospital and Birmingham and Midland Eye Center in clinical uveitis. He has earlier educated us and our audience about actionable intermediate uveitis. It was very interesting topic, and I will advise our audience to go through that lecture, and it will be very beneficial for them in their clinical practice. And today he is going to educate and guide our audience, particularly ophthalmologists, on this very important topic of anterior uveitis. So without further delay, I will request him to please present his talk.
Okay, thank you, Dr. Alim. It's my pleasure to be your guest again. Anterior uveitis treatment, what every ophthalmologist must know. So basically, anterior uveitis is probably the most common thing we see, and also one of the easiest to get almost right, but not completely right in every case. So because there is a difference between a well-managed case and a poorly managed one, is often not knowledge, it's attention to details. Also, it's one of the few conditions where your patient improve dramatically and still don't forgive you for the drops you schedule because you have to give an extensive drops. So first of all, we start with vital consideration. So our presentation will be on highlights on the key facts and key practical points in anterior uveitis. So basically, dilated fundus examination in all anterior uveitis cases is a must. Because without dilated fundus examination, we can't label the case as anterior uveitis in both eyes, not only the affected eye in case of unilateral, because many cases may have posterior segment involvement in the other eye and the anterior segment involvement in one eye. In severe cases, try your best to dilate the pupil with different types of mydriatics on first attack. The more effort that you do, the more chance for your patient to break the posterior synechia. So new posterior synechia is very critical. If you don't spend time and effort trying to break it on first presentation, you make it difficult. So one of the commonest things is use warm compress, putting full gloves in the clinic with warm water, and then ask the patient to put it over the affected eye with massaging and warming. This will help in that. And use all types of mydriatics. Use phenylephrine, use tropicamide. If you have midracert that we use for cataract, use it. All what you can to break the posterior synechia, and at the same time, this will help you to have a good look or a better idea about what's going on in the back of the eye. Family members with uveitis or related disease, like HLA-B27 related disease, like ankylosing spondylitis, is also essential and valuable. And don't forget to document in examination presence of scleritis or keratitis. In case of severe anterior uveitis, look for hypopyon and comment if it's present or not. And in most of my clinic, whenever I have a trainee with me and anterior uveitis, I highlight the importance of good negative, because when you write no hypopyon, it means that you looked for it and you didn't find it, not just it's a missed or it's not there. And this is what I want to highlight, a commonly missed fact about what's called DeWitt criteria. So DeWitt criteria is back pain onset before 45 years ago age and duration more than 3 months, or joint pain requiring general practitioner visit. If you have any of these points, any of these 2 points, then you should request HLA-B27. And the reason that I've mentioned this, because this can be a life-changing. Ankylosing spondylitis is a disease that can have a completely different outcome if you treat it early and diagnose it early. And I have seen patients, they presented with uveitis, and after 5 or 8 years, they presented with late stage of ankylosing spondylitis because the first ophthalmologist who assessed these patients, they did a full assessment and asked about DeWitt criteria. If they fulfill DeWitt criteria, then just request HLA-B27. It can make a huge difference. I don't request HLA-B27 as a routine, and I am against requesting it as a routine because 8% of population has a false positive due to 8% of Caucasian, they have a HLA-B27 gene. Regarding the uveitis complication, glaucoma is the commonest, 42% is uveitic glaucoma, and prevalence of uveitic glaucoma is variable. Cataract and CMO are also important complications. And here, my main focus today is how to treat anterior uveitis. This is a flow chart that I advise or I use in all my uveitis presentation, regardless the topic, because it's a way of thinking in any uveitis case. First, is there is associated systemic disease or infection? So you will answer either it's yes or no. So if there is associated systemic disease or infection, then you need to arrange with a special medical team systemic treatment, like rheumatology team in case of ankylosing spondylitis, or respiratory team in case of sarcoidosis or tuberculosis, sexual health disease in case of syphilis, in addition to ocular treatment. However, if there is no systemic association or infection, then you need to treat ocular disease. And as you can see here, there is 5 spectrum of treatment of ocular disease, 7 sectors. It can be very variable. The patient may use 1 sector or may have 2 or 3, or maybe he can pass by all these lines. It depends on the case. So the first thing is there is associated systemic disease or infection? It's yes or no. If no associated systemic disease or infection and I excluded this, then we focus on treating ocular condition. And again, how we treat. And first is topical steroid, as we know. And I really get irritated when anyone treat uveitis and give 4 times a day Pred 40, and the patient has 2+ cells. This is ridiculous. It's not acceptable. Your chance to control the disease on early presentation. So if you see a patient with severe uveitis, then you need to use an extensive steroid, especially in the first few days. So you need to, it can be up to half hourly in some cases. There is another alternative, which is available in US and I think some countries in the Middle East. I believe also in Egypt they have it, which is difluprednate 0.05%. There is an evidence that you can use it 4 or 5 like at a lower frequency and gives the same efficacy like 2 hourly steroid or 1 hourly steroid. But I don't have, like, we don't have it in the UK, so it's not something like I use at an daily routine. And the second point in topical steroid, which is critical, and I wish if every ophthalmologist do it, don't cut it on 3 weeks or 2 weeks. Don't cut it in 4 weeks. I recommend at least 5 to 6 weeks. Some cases 6 to 8 weeks. It depends on is it the first time or second time. Some cases I may extend to 3 months if it's recurrent. So don't give steroid for 4 weeks only. Usually it's not sufficient, especially if the patient presenting with 2+ or 3+. Usually they will have a flare up earlier. So usually we recommend to cut it over 6 weeks. Topical mydriatic and cyclopletic, as you know, breaking or preventing posterior synechia, relieving spasm or photophobia, as this is the main value. And consider anti-glaucoma medication in case of increased intraocular pressure. And anti-infective treatment, we may require systemic antiviral in case of keratouveitis, TB and syphilis treatment by specialized team. In severe cases, add dexamethasone ointment at midnight, because the main advantage, it acts at night and without disturbing sleep of the patient. So usually any patient with severe anterior uveitis, I give 1 hourly topical steroid, start by 1 hourly, cutting over 6 to 7 or 6 to 8 weeks. Dexamethasone ointment at night. I ask him to stop from midnight to 6 o'clock. Okay, and if it's really severe, I advise, and synechia is large synechia, I give atropine, not cyclopentolate. And here is the follow-up pathway and what I recommend. If severe anterior uveitis 3+ cells with fibrin or hypobion, you must see him in 1 day or 2 days, because usually with these cases, you don't have a good view for the posterior segment. And you assume that you try to see, the view is difficult. You are not sure how much is the posterior segment involvement. So when you see next day, especially with marked drop of vision, you if it's just anterior uveitis, then definitely it will improve within 24 hours, and the vision will improve, and you will have better chance to assess the posterior segment. Because if there is no good view, you need to take an action, and if there is no improvement, you need to take an action. Then you decide according to the response if you need to escalate the treatment, or sometimes if persistent and you can't exclude anything, you have to treat as an infection and take a tap. So it's very critical in these cases. Non-severe, you see in 1 week, because you want to make sure in emergency clinic or follow-up clinic, you want to make sure that is improving and responding well, and getting or following the standard pathway. Consider systemic steroid if not responding to topical medication, especially in severe fibrinous anterior uveitis. Confirm patient compliance first before escalating to oral steroid, because if the patient is not using, like using 3 times a day, and you ask it 1 hourly, then you need to stress on compliance. Make sure infection is excluded before starting systemic steroid, and you must use or do the baseline for steroid workup. If patient has 3 or more recurrent attacks per year, you need to consider first, you need to consider maintenance of topical steroid, or if not controlled on topical maintenance dose of topical steroid, you need to consider immunomodulation therapy or second-line immunosuppression if the patient cannot be controlled by topical steroid of twice daily or less, and has more than 3 attacks and still not controlled. Collaborate with other systemic specialists like infective systemic cause. You arrange with TB team or with this sexual health disease for syphilis. Refer to rheumatology in case of HLB 27. I'll give two highlights on two essential topics, which is the viral and the Fuchs heterochromia, because I need to deliver a specific message here. Suspect viral in case of unilaterality, increased IOP, decreased corneal sensation, diffuser sectoral atrophy, classic skin lesion like varicella zoster, long-standing chronic anterior segment inflammation, or resistant to major anti-inflammatory drugs. And here we need to treat with oral valacyclovir is the preferred antiviral drug, more even than acyclovir. Because the main advantage for valacyclovir also, it covers the posterior segment if there is any involvement or if the view is very bad and you can't see the posterior segment properly, then use valacyclovir because it works well for the posterior segment also. For herpes zoster virus, we use as per Titan guidelines, valacyclovir 1 gram twice a day to 3 times a day for 10 to 14 days. Other alternative is acyclovir. For varicella zoster virus, valacyclovir 1 gram PDS for 10 to 14 days, or again acyclovir as an alternative. Topical steroid like prednisolone acetate 1%. Beta blockers is, but take care here if there is corneal involvement or thing you need to be cautious and give a good cover for antiviral. Beta blockers is the agent of choice for increased IOP in viral, unless there is contraindication. And topical antiviral treatment can be considered in case of active corneal involvement. For HLA-B27, when to suspect if it's fluctuating anterior uveitis from one eye to another eye, or if the patient feel it before it comes, or early and aggressive treatment of acute episode with topical corticosteroid is essential here. It can evolve from anterior uveitis and become anterior and intermediate uveitis. Severe attack with hypopyon and fibrinous reaction, what to do? So here you need to use an extensive medication every half an hour. This is what I mentioned. And they make sure that the patient seen within 24 hours because you need to see the response. Because if they are not responding, you have to be proactive and start high dose steroid after exclusion of infection, definitely. Maintenance dose of topical steroid, you may end up by a maintenance dose of topical steroid as once a day with monitoring of pressure, intraocular pressure, as you know. And here, Fuchs, suspect in any young patient with posterior subcapsular cataract and vitreous opacities. If you find young adult with posterior subcapsular cataract, which is unilateral, and there is some vitreous opacities, rethink again and examine undilated to check for Fuchs heterochromia, and check the cornea carefully for very subtle satellite keratotic precipitate. Early diagnosis of Fuchs is important to avoid unnecessary treatment. This is the main thing. I have been in different hospitals and I have seen myself many times that they overtreat Fuchs heterochromia. And we should know a very simple rule. The risk for development secondary glaucoma in Fuchs has been reported to be 6.3 to 59%. So over-treating with steroid is useless. And the standard guidance, there will be a low-grade inflammation. It will stay there. Whatever you do, there is no value to continue on steroid. You will cause steroid-induced glaucoma and more steroid response. Especially that secondary glaucoma can be resistant to topical therapy. In literature, 66 to 73% of Fuchs heterochromic uveitis with secondary glaucoma require surgery. So the main risk is not the inflammation here. The main risk is glaucoma. Suspect, don't overtreat with a steroid, don't overtreat with a steroid again. So I put it twice because this is the main message in Fuchs heterochromia. There will be few cells, it will not go. It will stay forever. Forget about it. Don't treat it. And last thing in anterior uveitis, don't forget masquerade. It can be neoplastic or non-neoplastic. It may be account for 2% to 3% of all patients evaluated at tertiary uveitis clinic. Pigment dispersion syndrome, like non-neoplastic, a very common misdiagnosed as anterior uveitis. This is why you need to use transillumination of the iris to detect any abnormalities. Persistent epithelial defect associated with hypopyon also may be misdiagnosed as uveitis. Ocular ischemic syndrome and ocular trauma. Ocular trauma, by the way, is like it's not considered like uveitis. It's at the end of the day, just ocular trauma, traumatic uveitis. It's something which related to trauma. Thank you.
Well, thank you, Dr. Abdul Sattar. You explained anterior uveitis in great detail and the practical. You always guide our audience about the practical aspects, which are very important, especially you mentioned about today about this book's uveitis. Very important that was from practical point. So I was thinking about a question, Dr. Abdul Sattar, in a unilateral acute anterior uveitis, and there are KPs stellate, and there is iris atrophy, but there is no transillumination, iris transillumination. So what clinical features will prompt you to go for EchoStep and PCR, or rubella or herpes?
Thank you, Dr. Alim. So basically, the main issue here is the difference of diagnosis, because it's definitely better if we know exactly what we deal with. Usually here I'll talk about in the UK, we have a quite high threshold to take an AC tab in anterior uveitis. We have a very low threshold for AC tab in case of posterior uveitis when we suspect infection. But for anterior uveitis, we depend more on clinical thing. But if it's recurrent and not responding to the regular treatment, and I want to give a systemic antiviral as a long course, I prefer to take an AC tab because it will be justified. I don't prefer to give prophylactic antiviral or full course for prevention without lab evidence. Okay, sometimes this lab evidence may be in case of keratouveitis, you can get it just with PCR. Okay, for the swab. Okay, in case of keratouveitis, there is corneal involvement, and then you get it, then it will be quite straightforward and you can treat both. But if it's just pure uveitis, my threshold is quite high in resistant case, not responding to treatment, or case that I need to give a long course prophylaxis.
Right, right. Well, Dr. Abdul Sattar, one thing more I want, and our audience would love to know it, that this is your subspecialty, you are specialized in it. So what specific relapse rate or complications like posterior synecdoche or cystoid macular edema per year do you stop repeating periocular steroids and start thinking about immunomodulation like methotrexate and these drugs? How many recurrences and what complications in a year? How many times you feel it's time to go for these
So
immunomodulation?
the step ladder for or stepwise approach that I recommend for anterior uveitis case is first you treat with topical steroid, and then if the patient has more than 3 attacks per year of anterior uveitis, then I start to keep on a maintenance dose. I start with 1 drop a day. Okay, and then if it's still on 1 drop a day flare up, then I increase it and I keep on twice a day. If it's still on twice a day and the patient still has a flare up, then in this case I start in second line immunosuppression. It depends on the condition, either methotrexate or mycophenolate. We start, but this is a standard approach, yeah, that I follow.
Yeah, thank you, doctor. One thing more, we routinely operate these patients. As you mentioned, sir, that these patients develop cataracts, and ultimately we have to go for cataract surgery to restore the vision in these patients.
Yeah.
And we know that if we go in acute eye or not settled down eye, we open up a door of problems, more and more
Yeah.
problems. So, what is that in your mind the quiet eye time frame? Yeah, I mean, we should wait how much once the eye is that, then we can go for it.
So at least the standard guidance is at least 3 months is without any active uveitis. So we should have the eye free of inflammation for 3 months before surgery. So this is what I follow in my cases. Yeah, so 3 months at least without flare up, without any active inflammation. Yeah.
Okay, okay. 3 months minimum it should be given, quiet eye, and then it should be done. Surgery.
Yeah. There is
Well,
some exception. There is some exceptional scenario, but I'll not mention because this is at a uveitis subspecialty level. I need just to stick this to the general ophthalmologist. Yeah.
well, it was a very interesting talk, Dr. Abdul Sattar, and it is always a pleasure to invite you and learn from your experience and practical things, as I mentioned, that you always guide us along with the bookish knowledge. What are the practical challenges? And I believe these things are very beneficial for our audience also.
Yeah, thanks, Dr. Alim. And I think the take-home messages that I need to focus at the end of our topic and discussion is anterior uveitis is the most commonest type of of uveitis, as we know, and it range from 60% to 90%, depending on where do you work. Like in tertiary care level, it may be like 60%, but in district hospital or in secondary care or primary care, it may be 90% of the cases. And I don't think that any ophthalmologist will work as a general ophthalmologist or trainee will have like few weeks without anterior uveitis cases. It's very common. Having said that, but the management, I have noticed in different places and in different countries, the management is not up to the standard. So sticking to the standard management, using frequent drops, being aggressive in treatment, escalating their treatment according to the response, or if there is no response, and also counseling the patient because anterior uveitis, the patient is coming and he expects that if you don't counsel him properly, then he think or start to doubt about you because your treatment, you give me a treatment, and after 3 months or 6 months, it recurred. So your treatment is not effective. Or when you stop the steroid, it flare up. Then what I tend to tell my patients that it is the first attack. You may have it only once in your life, which is the smallest possibility, but you may have a flare up once we stop the drops. You may have a flare up after 2 years, 2 weeks, maybe 10 years or 20. There is no rule. It depends on autoimmune. It's an autoimmune disease and it depends on your immunity. So you need to put this in your mind. So it's not failure of treatment, it's the nature of the disease. A last thing, if you investigated the patient and the investigation was inconclusive, you must inform the patient that we did the investigation, there is no positive result. However, if you develop any new medical issue or new health issue, you need to inform your physician that you had uveitis so he can link the condition that is related to uveitis. Yeah, that's it. Thank you.
Thank you, Dr. Abdustar. It is a pleasure always listening to you and getting benefit from your knowledge and experience. I believe today's session will be very beneficial for the ophthalmologists who encounter this disease quite frequently. And I thank you on the behalf of our all virtual audience. And we will be looking forward more sessions to learn from your experience and knowledge. Thank you, Dr. Abdul Sattar.
Thank you.